fever is a very broad complaint. And therefore, if you get accompanying symptoms, that's when you'll be able to at least narrow down and focus on a few differentials. So just to categorize them, when I think of fever, I think of an infection, I think of malignancies. Some malignancies can present with fever. I also think of autoimmune disease. I think of drugs, and I think of an endocrine issue. So that's a number of things I think about. And again, if you talk of a rash, you could be speaking of almost the same things. I mean, a rash can be due to an infection. Okay, not very commonly, and therefore I'll shy away from mentioning it malignancy. But yes, I mean, you can have some kinds of malignancies presenting in the rash, just to use that loosely. And then with autoimmune disease, we know, yes, you can have autoimmune diseases presenting in the rash. And then drug reactions, definitely, you can have a drug reaction presenting with a rash. And then endocrine issues, I'll try to think hard about that. So we have a number of differentials here. So I think history will help us to determine what is going on.
Okay, so we move on with the HPI. Um, this patient was well until 1 week ago when she presented with fever, which was on and off. It was associated with night sweats, but it responded to paracetamol. She also reports painful neck swellings, swelling of the lips, nose, and eyes, and numbness of the nose. The rash started 2 days ago. It began in the upper and lower limbs, and it progressed to involve the torso, neck, and face. It is extremely itchy, but she denies cough, sore throat, nasal congestion, eye reddening or tearing, painful micturition, vaginal discharge, mouth ulcers, abdominal pain, diarrhea or nausea or vomiting. She reports no recent travel and no close contact to a person with a similar illness. That's HPI.
Okay. Um, Again, helpful but complex. So we are talking. It's an acute. We are still in the acute territory. We are talking of a 1 week history of fever. The fever is on and off and associated with night sweats. So that's a constitutional symptom. What I'm thinking about is, yes, there is some inflammation going on. Again, fevers and night sweats, it can be anything. An infection can present that way, a malignancy can present that way. And of course, some autoimmune diseases can present that way. So uh, it's associated with painful neck swellings. So yet to conclude on this, but what are the swellings that we are talking about? Is it lymphadenopathy, or what exactly is it? So I think physical examination will help us to be sure about what neck swellings we are talking about. And then there is also swelling of the lips, of the nose, eyes, and numbness of the nose. Okay, so swelling. The lips are swollen. The eyes are also swollen. Okay, I'll need to think very hard about this. What's going on? So I'll just proceed with the rash. So the rash started in the upper and lower limbs, progressed to involve the torso, neck, as well as the face, and it's extremely itchy. So I talked about accompanying symptoms. When we talk of fever, we already mentioned broad categories of differentials that would be at play in the particular patient. But then to narrow down, if we can localize, for example, if you are talking of an infection for fever, you need to determine where the focus is. So this patient doesn't have a cough, also throat, nasal congestion. So this one, um, at least reduces the possibility that the focus is within the respiratory system, both upper as well as lower. And then the patient also doesn't have eye reddening. So we are talking about something like uveitis, conjunctivitis. There is no painful micturition. So trying to rule out a urinary tract infection, although a lower urinary tract infection isn't expected to present with a fever. The patient doesn't have PV discharge, and again, no GI symptoms. So recent travel, yeah, I mean, if someone travels to another place, that would be a risk factor for some infections. But assuming that the patient is Tanzanian, it's the tropics. We have most of the things here. So uh, someone doesn't wouldn't need to travel somewhere else in order to get most of the infections that we have here. And then no close contact to a person with similar complaints. Okay, so this to an extent, I mean, at least it tells you that maybe she didn't get it from someone else, but at this point we cannot rule out an infection. So, because this is the end of the HPI, talking about infections, we have a number of viral exanthems which can present with fever and rash. So you are talking of things like measles, um, things like varicella. Yeah, so at this point we are talking about varicella. So measles, varicella, and I believe we have a number of others. So those are just a few examples. That's a viral exanthem. And then you have other. I mean, there are also other infections which can present with fever as well as rash, because we haven't heard I think about the description of the rash. So at this point, we can't confine ourselves to just a few infections. If we are talking of infections, I just mentioned a few viruses, but again, uh, we can have more. We can think of more other infections, all the way from bacterial infections as well as fungal infections. So an infection is a differential here. What exact organism we are talking about uh, can't really narrow down at this point. But then infections a likelihood, and then another thing I also talked about autoimmune disease. So autoimmune diseases, I mean, commonly, if you talk of something like SLE, for example, SLE can present with fever and constitutional. So the constitutional symptoms like fevers, uh, maybe not so much of night sweats. But then when you talk of rash, we also know that SLE can present with a rash. But the rash that we hear here is presenting in upper and lower limbs, and also involving the torso, neck, and face. So commonly, a rash of SLE, we know we can have an acute rash of lupus. So the malar rash that we talk about commonly. So the others like discoid, they are more of subacute to chronic. So this rash involving both upper and lower limbs, I do not really think it would be a rash of SLE. But then you also have other autoimmune diseases, the inflammatory myopathies like dermatomyositis, they do present with rash. But then we didn't hear about other symptoms that are telling us the muscles are involved. And of course, for SLE, again, we didn't hear anything about joint involvement unless I'm missing something. But yes, so autoimmune disease is a possibility, but then we do not have pointers that are pointing us in that direction. And then drug reactions like so you have something like dress, something like dress can present in a similar way. So you have dress is a short form for drug reaction with eosinophilia and systemic symptoms, I believe. So systemic symptoms include the fever, and all the other symptoms we are hearing about, uh, and rash. But then, so this is a condition we haven't heard about a drug history of the patient. I think it would be important to hear about the medication history in this patient in order to see if a drug is a culprit in this patient. So yes, the duration is short to think about a malignancy. And to be honest, malignancies, I know they can present with fevers, night sweats, and other constitutional symptoms, but uh, at least at this point, I believe there's something like that. But if on the fly, I cannot think about a malignancy that presents with a rash like this one. See, so I know some malignancies can have an involvement in the skin, uh, leading to itching. But then I think with this acute onset of symptoms, I'm not very much convinced to think about a malignancy. So at this point, I think most of my sense with an infection and with the drug reaction. So malignancy, autoimmune disease, along the list, and then an endocrinopathy. So talking about an endocrine disorder presenting with fever as well as a rash, I can't think about any on the fly right now. So let's proceed and get more details and see if I can organize my mind more.
Um, Thank you very much. Uh, that was well elucidated. I love that discussion. Okay, so let's proceed. Oh, okay. So we move on to the review of other system. Nothing significant here. The cardiovascular system, neuro, and musculoskeletal were all normal. And past medical and past surgical history, patient is known with primary infertility, but she has no previous surgeries. Meds, she's on allopurinol, which was started 3 weeks ago, and also paracetamol, which was she uses right now, PRN for the fevers. Family and social history, she's married, she doesn't have kids. Her parents are alive with no known illnesses. She works as a banker. She drinks alcohol socially, and she doesn't smoke, and she doesn't use illicit drugs. That's it.
Okay, so review of systems, non-contributory, as just like we're thinking in the HPI, trying to rule out some differentials. We see the musculoskeletal system, nothing significant. CNS, cardiovascular system, nothing significant. But then uh, in the medication history, she's using paracetamol PRN for the fever, but we hear the patient is on allopurinol for the past 3 weeks, and this is unexplained. So we are not sure what was the basis of starting this allopurinol. And since one of the things that I talked about is a drug reaction, I would like to hear more about this allopurinol. The family social history, I see nothing significant. The patient is not on any, she doesn't use any illicit drugs. And then also occasional drinker. And of course, saw nothing in the family and social history that is contributory. So I think I'm concerned about this allopurinol that the patient is using. We haven't had the grounds on which it was started, but then we are talking about this patient who is presenting with an acute onset of a fever and rash, thinking about an infection. We can't we didn't find a focus of that infection. Of course, we have another differential, which is due to drugs, a drug reaction, and we hear the patient is on allopurinol. So, as I said earlier, that medication history will tell us more. So we have allopurinol here. The paracetamol started after the fevers, but then we have allopurinol started a few weeks ago. So that will be one of my differentials. What I just mentioned, dress, is one of the differentials in this patient. So I'm thinking about a viral exanthem. And then, so at this point, I should say a viral exanthem. So commonly, at least some of the things that I mentioned about, maybe not so much about varicella, but measles and other viral exanthems, commonly they have some presentation in the upper respiratory tract. Someone will have a sore throat. Someone will have something in the mouth. For example, we haven't come to physical examination yet, but the patient will have some symptoms in the upper respiratory system which we haven't had. So still, I'm thinking about an infection, especially viral ones, but I think dress is coming to the top of my list.
Yeah, that's nice. So maybe before we proceed to the physical exam, you can summarize the case for the people who joined later.
Okay, so Joseph has been presenting a case of a 35 years old female uh, who presented with a 1 week history of fever and a 2 days history of rash with a non-contributory, I should say. The review of systems was unremarkable, and the patient didn't have any symptoms that are pointing us to a particular focus. Uh, this patient has primary infertility. That's what is significant about her past medical history. Otherwise, nothing else. And then she's a social drinker, not smoking, not on any illicit drugs. And her medication history is significant for using allopurinol for the past 3 weeks and then currently on paracetamol for the fever.
Yeah, that's a nice summary. So let's proceed. So on the general exam, she's alert and oriented to time, people, place, and events. She's febrile. She's not pale. She's not jaundiced. She has tender and firm and large lymph nodes in cervical, preauricular, axillary regions, both axillars. She has a normal oropharyngeal mucosa, but she doesn't have lower limb edema. Let me admit someone here before we proceed. Okay. So the skin exam, she has generalized papules on erythematous base with excoriations, which are involving the face, the neck, the upper and lower limbs, plus the torso. Her vital signs: she has a normal blood pressure of 111/77, a pulse rate which is 87 normal respiratory rate of 16. She's febrile at 38 degrees centigrade, and she's saturating normally on ambient air. Systemic exam were unremarkable. Per abdomen, cardiovascular system, chest, the neuro, musculoskeletal were all normal. Yeah.
Okay, so basically it was the general exam that was significant. We see that the patient has lymphadenopathy. The patient has lymphadenopathy and mostly cervical, preauricular, axillary. Okay, uh, and then a normal pharyngeal mucosa. So I mentioned about measles, right? I mentioned about measles. Uh, we know measles has a presentation in the oral cavity, we would see some findings. And then, so the patient has a tender lymphadenopathy, and then she's febrile, and then we see a rash that is maculopapular, I would say. This is a maculopapular rash. Uh, and then with some excoriations, I believe from the itching.
Mhm.
Okay, so something else that I'll talk about, I think it's as I said earlier, I'm thinking about dress as one of the differentials, especially after the medication history, hearing that the patient is on allopurinol. But at this point, I cannot throw out infections completely. So I think one more infection that I haven't thrown in is an acute retroviral syndrome. Acute retroviral syndrome or acute HIV infection, I should say, to be clear. So patients with acute HIV infection can actually present with a fever, a rash, as well as generalized lymphadenopathy. So this doesn't qualify to be called a generalized, but then we haven't heard about other areas like inguinal lymph nodes and other areas. But then the patient has tender lymphadenopathy, has a fever, and has rash. So an acute HIV infection, I mean, is something. But then the problem with acute HIV infection is you do not have serological tests to rule it out. So if you would want to consider that and rule it out, maybe uh, you need to do a PCR in order to be able to rule it out. But acute HIV infection can present that way. And then, so for some of the especially viral infections that we talk about, can present with splenomegaly or hepatomegaly that we do not see here, but it's not a must for them to present that way. So that is not enough for them to be ruled out. Yes, so I'm still at the same point. What I'm thinking about is there's inflammation going on. I should say so. There's inflammation going on. Okay, the patient has fever. The patient has lymphadenopathy, and then there is a maculopapular rash that we see. That can happen with a lot, except if we talk of something like varicella. Okay, varicella, well, the rash can also be maculopapular. So at least for some of them, I think for this patient, we can talk about something like herpes, for example, which can also present if you are talking of disseminated herpes simplex. They can present with the rash, but then when we come to physical examination, we talk more about vesicles rather than a maculopapular rash. So some viral infections are more likely than others in this patient. So yeah, I think we should just go to the labs and see. But on top of my list, we are talking about an infection, especially a viral infection. But then a drug reaction is something that I'm seriously considering.
Yeah, David, I don't know if I heard well. You said this doesn't qualify to be a generalized lymphadenopathy. Or did I hear?
Okay, so uh, the lymph nodes you have in the cervical, preauricular, okay, we also have in the axillary region. Okay, so yeah, so including the axillary region there, okay, this is possibly generalized, but
No.
then because yes, if we have also lymph nodes in the axillary area in addition to the head and neck, then that is generalized.
Yeah, I think the definition is uh, at least two in two different non-contiguous sites. So yeah,
Yeah, non-contiguous sites. Yeah.
yeah, only that. So
So head and neck
mm,
plus axillary, yes,
mm,
that is generalized.
yeah. So let's proceed. And maybe you touched on EBV. When people do the exam in the theory test, where they see fever, lymphadenopathy, EBV. Is there a way that you can tell that this is not how EBV presents, and maybe in some sort of way, what is pulling you away from EBV and putting addressed up there?
Okay, so I pointed out earlier. So you talk of Epstein-Barr virus in a presentation like this one, you're talking of infectious mononucleosis. As I said earlier, for something like infectious mononucleosis commonly, in addition to the lymphadenopathy that you see, and again, the patient doesn't have a sore throat, you see, the patient doesn't have a sore throat. A sore throat is common. I mean, because we read and forget. I cannot tell what's the frequency of sore throat in patients with infectious mononucleosis. But then I believe a large percent of those patients present with a sore throat.
Mm.
Uh, and then on top of that, infectious mononucleosis commonly presents with splenomegaly. Yeah, so I mean, the absence of a sore throat, the okay, splenomegaly, maybe not that much. Again, I do not remember the frequency, but those two make the possibility of infectious mononucleosis low.
Yeah, you're on point. You're on point. So let's move to the labs. And his white count was slightly elevated at 10.3. Machine's upper limit of normal was 10. Predominantly lymphocytosis, absolute lymphocyte count was 5. Eosinophils was also elevated at 1.35. HB was normal at 13. Platelet was mildly reduced at 121. AST elevated at 52.2. ALT elevated at 49.5. ALP was normal. GGT was 78, also elevated. Bilirubin, total and direct were normal. ESR slightly elevated at 25 according to the machine. Her creatinine was normal. BUN was reduced at zero point 0.8. Urine analysis, proteinuria of 2 and blood of +3. MRDT was negative, RBG normal 5.2, HIV, RPR, hepatitis B surface antigen, hepatitis C antibody were all negative. That's what we have for
Okay,
the labs.
so for the labs, the full blood picture, we see that there is leukocytosis with the predominance of eosinophils. So this is very significant. You see an eosinophil count of more than 1. Yeah, that is significant. So we have significant eosinophilia here because the upper limit is 500. So the 0.5 that you see there. And then here we have 1,300 and something. This is significant eosinophilia. The platelet count is low, and we also see a picture of some hepatitis in this patient. So yeah, you have transaminitis, elevated AST, ALT, as well as GGT. So it's some slight cholestatic as well as hepatocellular picture. And then elevated ESR, the patient is inflamed. So coming to the other labs, creatinine, so a low BUN, you get a low creatinine, a low BUN, nothing significant about it. But the urinalysis, you have protein and then blood. Okay, so this could be a glomerulonephritis. That would be a possibility. And then for malaria, so commonly, yes, malaria can present with a fever. We commonly do not think of malaria in terms of a rash. I mean, maybe I can get some new knowledge here, but commonly malaria doesn't present with a rash. So I didn't mention it as part of my differentials to begin with. But I mean, testing for malaria was important because uh, things can coexist, and therefore I think it was important to test it. HIV, I believe this is a rapid HIV test, uh, a bioline most likely. So I commented earlier that if we are thinking of an acute retroviral syndrome, uh, which is a possibility in this patient based on the presentation of fever, the rash, as well as the generalized lymphadenopathy. Although there is one thing about HIV that is almost pathognomonic, uh, posterior cervical lymphadenopathy. So you see a posterior cervical lymph node, very typical of HIV, although I can't say 100%. But a rapid HIV test, because you are testing for antibodies, if it's an acute infection, you are not likely to get a positive result because the patient hasn't seroconverted. And therefore, if you need if you need to confirm that diagnosis, then you need to do a PCR test. You need to do a PCR test. So with the serological tests that we have, and I think the ones which are commonly available in our setting are third generation HIV rapid tests. You would need a month or more for them to turn positive. Since infection, you would need a month or more. While acute retroviral syndrome, the presentation can be anywhere from a week up to 6 weeks. The patient will start with the presentation of the acute retroviral syndrome. So a negative HIV test doesn't rule out an acute retroviral syndrome, but then that's not high on our list uh, because we wouldn't expect an acute retroviral syndrome to present with eosinophilia. So if we put things together, I wouldn't keep that high on my list. And then RPR, of course, important. I mean, syphilis can present with anything, but then negative as well as hepatitis B and C. Yeah, so coming back to the full blood picture, we see eosinophilia, and then we see some picture of transaminitis, an elevated ESR inconsistent with inflammation, and then a picture plus or minus in keeping with the glomerulonephritis. And therefore, if I talk of systemic symptoms, we see systemic symptoms here. Uh, if I talk about eosinophilia, we see eosinophilia here. So my confidence that we are dealing with stress keeps on increasing. We have a drug reaction with eosinophilia and systemic symptoms. So yes, I think that's what is on top of my list at this point.
Sure. Um, yeah, not much to offer today.
Yeah, so I think I've already committed. We are talking about dress. I believe uh, another form, another nomenclature for that is DIHS or DHIS.
Uh,
I can't remember the long form of that, but I'm used to dress.
yeah. Yeah. So, um, truly, as you're saying, I diagnosed the patient with stress. Also, yes, the another name is uh, DIHS, drug-induced hypersensitivity, I think, syndrome. So, DRESS, as you correctly said, the drug reaction with eosinophilia and systemic symptoms. And the culprit, truly, as you're saying, I also thought it was allopurinol, which was started 3 weeks ago. And so I prescribed this patient with a topical clobetasol and desloratadine, but it didn't help. You know, what we have in many hospitals in this country is a tube, small tube. So someone with a rash everywhere, they use it for one day and it's over. So patient came back just a day after. So I transitioned that to pure prednisone at 40 milligram with a subsequent taper. And so she had improvement over the following weeks. The itching subsided. There was no new rash formation, and the present rash slowly subsided over a month. So I withdrew the allopurinol and I didn't press her on another urate lowering therapy because she didn't have an indication as I thought out. Her CBC liver enzymes the normalized over the following month, and so I have some few teaching points for you. Yes, David, fever and rash. This is a schema that I took from the clinical problem solvers. It is online there. Anyone can check it out. And so much of the things you mentioned here, the infections, which can be viral, bacterial, viral can be the infectious mononucleosis or infectious mononucleosis, like, as you're saying, HIV, CMV, BV, zoster, parvo, B19, mycoplasma pneumonia, group A strep, syphilis, gonorrhea, even TB. And yes, the drugs, dress, the topic of today, SJS 10, I didn't hear taking that. And without forgetting AGEP, I think acute granulomatous exanthematous pustulosis. And yes, some malignancy. I've read about. I've never seen it, but I've read about the cases with fever and um, rash that are caused by cutaneous T cell lymphoma. Even leukemia can present like that when you have infiltration of the malignant cells to the skin. So yes, autoimmune diseases, you mentioned them: SLE, vasculitis, adult onset stills, sweet syndrome. So these are an approach. Other learning points that I have for you guys. Um, so the features that define dress includes an extensive rash like this one, what you are seeing in this patient, and visceral organ involvement, as David correctly said. It seemed on the labs that the liver is affected and the kidneys are affected because this patient was attending at that hospital before. I looked back and I didn't see glomerulonephritis picture on our UA. And then after I treated her, later on I could screen the urine and the blood and protein were gone. So I also think it was two organs were affected here. Lymphadenopathy were there, which attend her. And lymphocytosis, we also saw this on the CBC, and eosinophilia, which defines the disease. But not necessarily. Eosinophilia, that's the reason the name was changed from DRESS to DIHS, because some cases can present without eosinophilia and still they have to be defined as DRESS or DIHS. The latency period is 2 to 8 weeks. This patient used the drug for 3 weeks. And what I saw, and it was very scary for me, is that 2% of patients, there is no history of using drugs. So I had to keep it here to remind myself, maybe one day I will see something and ask the drug if there's no drug, I should also consider dress. And so the high risk drugs include allopurinol, the culprit in this patient, anticonvulsants, antibiotics. If you look at them, they all start with an A. So think of an A. The pathophysiology, this is a T cell mediated hypersensitivity reaction. So a type 4 delayed hypersensitivity reaction. The cause of the disease, so the rash will persist for at least 15 days. And from there, in 90% of patients, it can then start to subside, but completely cover, it takes weeks to months. This is very important because, this patient is educated, is a banker, and then she's there, you are giving her medications, you are telling her is the allopurinol is causing this cold dress, but nothing is happening for 1 2 weeks. The disease is there, and so you have to cancel. So she kept moving from one doctor to another. Things were being prescribed, but again, after those days, yes, the disease went well. So the flare, there can be a flare. The disease can come back again, even without being given decapit medications in quarter of these patients, and can occur weeks to months from the resolution of the disease. How we treat it, it depends with the severity. So if it is mild, you just give topical steroids. Mild is it's like there is only a single organ involvement, and they don't need yeah. And severe is that there is two or more organ involvement, or they need an ICU care. So if it's severe, you give systemic steroids, or alternative, you can give cyclosporin and IVIG. How to prevent this? One and most important, you should avoid unnecessary prescription of high risk drugs. Like in this patient, this was so unnecessary. Her, I looked back how it was prescribed, and then she presented to the hospital with flu-like symptoms. Uric acid was screened. It came back. It was 460. Yes, and then the upper limit of the machine is 360. So it's just 100, and then prescribed allopurinol. Yes, in other patients goes unnoticed. They never get dressed, but here it is. It is dressed, and it's so hard to explain to her that you don't need this medication which caused this disease. Another thing, in countries, there are countries, especially Asian countries, they have very high risk of dress from allopurinol. So they do screening, they do HLA genetic screening before they start you these high risk medications. And sure, you should educate this patient. Like this patient, you're telling her that you are at risk of getting this disease. So avoid allopurinol, and whenever you want to be prescribed medication, tell the doctors that you have this, because if you have dress today, it means you are genetically susceptible. Maybe you can be started an anticonvulsant one day and still get another dress. Plus the family members, because it seems there is a genetic uh, uh, part to this disease. Yeah, so that is it today, David. Congratulations, nice job. You had everything today. I learned so much from you, and I think everyone else learned from you. Maybe you can hear from you.
Thank you very much. I should say I learned a lot from you because you broke the case, and then with the which if you don't mind, you can post it again so I can see a number of differentials that I completely forgot about
Yeah,
the schema about fever and rash.
sure, sure, you got it. Yeah.
Yeah, so when I was talking of start with malignancy, so I thought about lymphoma and leukemia. I know, so there are things like do we call it Sézary syndrome, or what exactly is it? Yeah, I remembered about that, but then uh, sometimes thinking about differentials is I think about the kind of rash we are talking about, and then I see it's not typical. So for something like SJS and 10, would expect to hear something like the skin peeling off. So that's why I didn't mention it, but
The mucosa
I
involvement.
think it was important. Yeah, I think it was important to mention it. So I see there's a lot of differentials actually. I mentioned the broad categories, but then I think I was a little narrow in the number of differentials that I mentioned. And therefore, I think this was educative for me because I've added a number of things that I was supposed to consider. Yeah, so I should say I actually learned more maybe than the rest of you, because the process and then coming to reveal, especially this slide here, made me think about other things that I didn't consider before, and therefore I need to consider in the future. So thank you very much for the learning opportunity.
Sure. Okay. Do you have anything from the floor? We were late today, and I think we won't waste much of your time. If there is anything, a question, a contribution from the floor.
So Yes, I see a hand. Kazaura, karibu.
Hello, guys. How are you?
You're fine, Kazaula. How are you?
Good, how are you doing?
Thank you for the nice presentation. A good case. I was just wondering why was this patient started on allopurinol?
Uh,
Was there uric acid tested, and what were the results?
yeah. So thank you very much. That's a nice question. So yeah, this patient presented 3 weeks back before the current presentation with the complaint was general body malaise, and they were tested malaria, etc. It was negative, but um, they also tested uric acid, and then the result was 460. The machine's upper limit of normal is 360, and then she was started on allopurinol, but still uh, it was unnecessary. So the American College of Rheumatology, I think it's 2020 guideline of gout and hyperuricemia, it recommends against starting urate lowering therapies to people with asymptomatic hyperuricemia. Yes, there are other school of thought. For example, if it's super high, for above 700, for example, they think okay, maybe there is a risk, and then at least to those patients. But I describe it as unnecessary, and that's why I stopped it, and I didn't start anything in this patient. I just canceled down lifestyle measures. What do you think, Kazaura?
Very sorry, someone. Very sorry, someone was calling my phone, so I, I, I did not hear anything.
Yeah, so what I said in summary is that um, yes, she presented with another complaint. She had a general body malaise, and she was checked for uric acid. It was 460. Upper limit of normal for the machine is 360. They started allopurinol, but I deemed it unnecessary prescription. That's why I withdrew the drug, and I didn't keep this patient on any urate lowering therapies as far as the ACR guidelines are concerned.
So, if I hear correctly, you said for patients with asymptomatic hyperuricemia, there is no need of prescription of allopurinol for febuxostat. Is that right?
Yes, it is. It is not indicated.
Why? Because you can have with high level of uric acid, at times you can develop stones, you can develop things like nephropathies. Why is not indicated?
Yeah. Um, so let's talk about. So the diseases are urate crystal deposition in this um, organs, the joints, gout, the calyces, kidney stones, and the nephrons. You are talking about uric acid nephrosis, nephropathy, I think. So, for example, gout. It's only 4% of the individuals that are having gout who are having hyperuricemia, but more than 20% of individuals in this community they have hyperuricemia, and these diseases are easy to treat when they come up. For example, if I have a gout today, it's so easy to treat. You just treat. There is no problem. So many people with hyperuricemia will not get these diseases, and that's why it is not indicated to give them drugs. You are not preventing anything actually. So actually, if you look at the if you I read this topic, if you look at the reference that they do cite, there are researches that people with hyperuricemia they are given these medications and then they are followed up, and you see there is no difference between those who will develop gout and those who will not develop those diseases.
Okay, thank you, Joseph.
Okay. Yeah, thank you,
Dr.
Kazaura, for the questions. Yes, Mudhir, karibu.
When he was presenting the investigations, if I remember correctly, you said that the BUN, since the creatinine it's in normal range and the BUN was slightly high, you said that it was not much significant. But for the proteinuria and the blood in urine, you were thinking of glomerulonephritis. Can the dress present with the glomerulonephritis, or can it explain? I mean.
So the BUN was actually low, if I noted that correctly. Is that right, Joseph?
Yes, the BUN was 0.8, it was low.
Yeah, so the BUN was low, and when I see a low BUN and a low creatinine, it's not concerning any. I mean, I'm not concerned about anything, except if you have someone who is, for example, who is very much wasted, because creatinine, especially creatinine, comes from muscle basically. So uh, muscle and protein. So if I see a low BUN and then someone has lost a lot of weight, I'll just think it's because of the wasting. But otherwise, low creatinine and BUN, they do not have diagnostic significance. Yeah, as far as any pathology is concerned. So this patient had a low BUN rather than an elevated BUN. But yes, the blood and the protein, I thought about glomerulonephritis.
Yeah. Thank you, Mudihir, for the question. And David, I think that's a fair answer. And one thing that we do here in AfroDX is so we keep the cases they are. So if these were the lab findings, I put them here, and you see the mastery that David has. He sees it and he doesn't panic. He said, "Okay, I'm not concerned. Maybe it's the machine. Actually, it was the machine in this patient, because later on I was repeating when I was following the patient up, they came back normal. So yeah, thank you, Muzaid, for noticing that.
Yeah, so I do not see any other hand up. Uh,
Okay.
so if there are no other questions, I'd like to thank everyone. I think the attendance was good today, but a number of people left just after, I think, just after the learning points that Joseph presented. But we are happy that a number of people joined, and I actually saw new names today. So I believe the outreach has been good. I mean, people are sharing the link. We see new people joining. Therefore, we get to share knowledge with many people. So uh, I encourage everyone to do the same. So when we share the links, make sure you share with others so many people can join us and we can get the opportunity to learn together. Again, I should repeat what Joseph is saying every day. If you have any cases, if you have any case that you think uh, can be presented in this platform, just reach any one of us. Even if it's not well organized, I know Joseph is very organized in his cases. But what we need is to give ourselves a challenge. And so, even if the case is not very well organized, any case is discussable. So just bring anything, no matter how raw prepared it is, we'll discuss it that way, because as you see, we always have something new to learn from every single experience. So if you have any case, just reach any one of us and then we'll find a spot to present that case. So otherwise, Joseph, if you have anything before we close.
Yeah, so it doesn't need to be scleroderma renal crisis or whatever, even pneumonia, UTI. Just bring it up. There is something to learn. And yes, we are seeing an Noreen Omar is asking a very good question here. BUN of 0.8 was answered, and the proteinuria of +2. So David was explaining that dress drug reaction is eosinophilia and systemic symptoms. So the systemic involvement, it can include visceral organs, for example, the liver, plus the kidneys. So the kidneys were affected here. That's why they had a glomerulonephritis picture, proteinuria and blood in the urine. So far, I have nothing else to say here. We just want cases from people. I see there are people from Buganda and Udom and Muhas. Why are we not seeing? I'm in the street and I'm seeing cases. I believe you guys are seeing a lot of cases. Then maybe you don't have the guts to present. Just come and present. We can help you if you can. Just you give one of us and we present it together with to another one of us.
Yeah, and then for the future again, I think we should also have new discussants.
Sure.
I guess I guess people are getting tired of me now discussing every single weekend.
Sure.
So we should get new discussants, even if it's someone to discuss together with me or with Joseph, because I believe in a few months I'll have a case or two to present to Joseph.
You always say a
So
few months. You always say a few months.
yes, but in a few months I will.
Okay. I'm waiting.
Okay, so thank you everyone for joining. If there is nothing else, have a good night and make sure to share the link next weekend when we do. Share with others. Good night, everyone.
Good night.
Okay.